All right. It's been a little bit since I streamed this, but we're going to dive back into full code. A little tilted, but that's fine. Fire off the stream tilted. It's the GoBot special. Do I need any medical paraphernalia? I think I need to liven up my background. Problem with this camera is that I won't be able to see my medical paraphernalia that I'm wearing for funsies. Well, I guess let's try not to kill some patients. Let's look at the current saved and unalived counts. We are at 19 saved and 6.5 unalived. Hopefully that number doesn't increase this time, but I'm a little rusty. Haven't taken care of patients in like 3 weeks, 4 weeks. It's been a while. I've been doing mostly interviews for residency. Let's see. Hopefully it'll give me an easy one to start off with. These daily ones are usually pretty hard, but let's see. 71-year-old male admitted 2 days ago for cellulitis to infection of the skin layer. Found minimally responsive after an unwitnessed fall. Okay, so trauma to head. Rapid response team at the bedside. Okay, so he was admitted 2 days ago for an infection, and then nurses found him unresponsive after a fall. Or no one saw him fall, but they found him unresponsive on the ground. They placed a cervical collar here just in case if he has any neck fractures. Always important with any kind of trauma like this. And then one peripheral IV in place. Okay. So he has like a sepsis, cellulitis picture going on. Maybe that made him fall. But you got to think of other reasons why he could have fallen. Could he have a stroke? Could he be bleeding somewhere? Could he be anemic? Could he be fluid depleted? So when he got up, he got dizzy and fell. Could he have a brain bleed when he hit his head on the ground? A lot of different things that can come from this initial presentation to what is happening today. Could have a blood clot or a heart attack as well. So we'll see. All right. So he's admitted. Nursing just called, found him immediately responsive. Not great. Hey, what's up, buddy? Hello. Oh, he's not very talkative, it looks like. Nothing new with this. He had AFib. If he's not on blood thinners, that could cause like a pulmonary embolism, but he is on blood thinners. We'll check that to make sure his blood is fluid enough and not causing blood clots. The warfarin's actually working. Let's see how he's doing. How you doing overall, man? Does not respond. Okay, he's not responding. All right, we should do a little more stuff then. Let's stabilize. Let's attach him to the monitor. See how his vitals are doing. His oxygen's looking good. His heart rate's low. Blood pressure's looking fine. Good. That's good. We have some time maybe. Let's get a second IV just in case because it's kind of spooky. He's pretty stable. He's not responding. Come on, man. Give me some responses. We'll look at him real quick. He's got a cut on his head. Hematoma. His equals are equal and reactive. Patient losing consciousness? All right, let's... Fuck it, let's intubate him. Maybe losing consciousness. I don't know, man. All right, suction, pre-oxygenate. Let's get some... Tomnate. Sucks. And then let's do it. All right. We intubated him. His heart rate is, so he's irregular, but his blood pressure is fine. So I'm not worried that the irregular heart rate is messing with his blood pressure and stopping his body from being able to perfuse. Check out the rest of the exam, see what's going on. I think we should get a CT scan as fast as we can because he hit his head so hard. I'm kind of worried about him. It could be a brain bleed, but it's hard to tell. You don't really know what's going on because he's not talking to you. So could be anything. Let's get a quick head CT. Huge bleed. Okay, so one second. I think I got to move some things along real quick before I talk too much. Let's give him some... There's stuff that can like bring fluid out of the brain. I'm not entirely sure. Let's talk to neurosurgery and see what they recommend. I mean, operating room. Make sure you have sent pre-op labs. Okay, let's send some pre-op labs. ABGs, type in screens, CBC, lactate, LFTs. Check out his heart's doing. Check if he's having a heart attack. Sure, we'll take a urine as well. Some other labs. He needs neurosurgery. That brain is being pushed to the side. So the brain is nice because you can kind of tell. You have like you can tell what's wrong because it's not symmetrical in this case. Symmetrical brains are very symmetrical. This huge concave structure. This white is blood on a CT scan like this, and it's concave instead of convex would be the other way, like a little hole, like a divot in it. It's likely an epidural hematoma from an artery that he ruptured. Okay, his blood pressure's getting up. Not good. Let's get him to neurosurgery. Let's give him neurosurgery for an epidural hematoma. All right. Look at that. Just like that. We saved him. There's some stuff we could have done a little better. Like we could have given him, okay, PCC. So it can, because he's on warfarin. So that was the main reason he had a bleed. It's because he fell, but it's also because he was on warfarin for his atrial fibrillation. So we give PCC. Let me get that in my little Anki deck so I can remember that. PCC is reversed by warfarin. And then you can also do osmotic diuresis as well. Some hypertonic saline. And that really helps suck some of that fluid out of the brain. And it's not the end-all cure for this, but it can help. This patient needs an acute intervention to save their life, but osmotherapy may delay herniation and help him. It's the idea of kind of like you're putting very concentrated solute in the body, in like the arteries and the vessels with this fluid, and it's gonna, because it's so hypertonic and has a lot of salt, it's gonna suck out water from less hypertonic or less concentrated water, which is all in the brain right now. It's the previous blood, it's the normal blood, and so theoretically you'll pull fluid out of there. And because the skull is like this, almost a cage that has no give, right? Because all the skull parts are fused together at birth. You need to be able to pull out water because there's nowhere for that water to go in the brain. It's just going to cause more and more pressure because of that bleeding. Pain control after intubation. I always forget that in this, but even just because you're, yeah, that makes sense. And I need a propofol effusion too. I just gave him temporary sedation. So I need to get back in the habit of doing this stuff. Okay. TDAP for surgery, sure, for laceration. Overall not too bad. Could have done more, but we got him to the care that they needed, which was neurosurgery. Not bad. That's a win. That's 20. 20. Oh, not 12. 20. Oof. That's good. That's good. Don't worry about that bottom number. But we should get on the daily. That's good. Wouldn't mind reading a little bit more. So fall in the hospital, epidural hematoma. So he was on warfarin, and to treat an epidural hematoma and increase intracranial pressure, you can give some osmotherapy with hypertonic saline, and then warfarin reversal with PCC. All these different blood thinners like Eliquis, warfarin, I think even some of the antiplatelet stuff, they have reversal agents you have to give, and that's something I'm not the best at. I still need to memorize a lot of that. But PCC, prothrombin complex concentrate, that is good for warfarin. Warfarin's a little outdated. Not as many people put on warfarin anymore. It's very dangerous and it's kind of finicky. Sometimes you can get overcoagulated. We didn't check an INR in this patient, but that's how you would check. Bleeding times is how you would check to see if the patient's overbleeding or the warfarin is affecting them too much. PCC, prothrombin complex concentrate, PCC. CRASH 3 trials showed that TXA reduced early head injury in patients. TXA could have been something we did as well. Interesting. The CRASH 3 trial showed that tranexamic acid, TXA, administered within 3 hours of injury induced early head injury deaths, reduced early head injury deaths in patients not at or close to the point of death. Interesting. Okay. So automatically activation such as mannitol or hypertonic saline, only temporizing. The OR was the end-all be-all to save this patient. Could have ordered some other stuff like glucose, that's a good one. Coagulation panel. I forgot to do the C-spine. I think he was fine. This seemed more like a leading injury. I was all right. Could have done better. Still passed. Saved him. Could have been a lot worse.